welcome to the ASCO Guidelines podcast, one of ASCO's podcasts, delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcast. My name is Brittany Harvey, and today I'm interviewing Dr. Joshua Royce from Georgetown University, co-chair on Therapy for Stage 4 Non-Small Cell Lung Cancer with Driver Alterations, ASCO Living Guideline version 2025.1. It's great to have you here today, Dr. Royce.
Thank you. Happy to be here.
And then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Royce, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So to dive into what we're here today to talk about, Dr. Royce, this living clinical practice guideline for systemic therapy for patients with stage 4 non-small cell lung cancer with driver alterations is updated on an ongoing basis. So what prompted this latest update to the recommendations?
Yes, thank you. It's very important that we have living guidelines that are continuously updated. We obviously don't live in a static environment where things are non-changing, and we really need to apply the most up-to-date and current evidence to treat our patients with the most effective strategies, the most groundbreaking strategies. And so to have guidelines that can be disseminated, particularly these ASCO guidelines, to treating providers is incredibly important. So with any of these updates, we review ongoing studies, published work for the quality of evidence to see if it's something that warrants making adjustments to our guidelines, or at least incorporating the information so that providers can review it and incorporate this into their own personal decision-making. So in this particular update, we reviewed evidence particularly pertaining to EGFR mutated non-small cell lung cancer and non-small cell lung cancer harboring an NRG1 fusion.
Yes, certainly there's a lot of new evidence in the advanced non-small cell lung cancer field, and so we appreciate the panel's continuous review of this evidence. So then you just mentioned two separate areas where the panel reviewed new evidence. So starting with that first one, what updated evidence did the panel review on first-line treatment options for patients with EGFR alterations, and how did this impact the recommendations?
Yes, so advanced EGFR mutated non-small cell lung cancer, at least with classical activating alterations, that is our exon 19 deletions and our exon 21 L858R mutations, is something that's really evolved rapidly in the last few years. For many years, we basically, for the frontline treatment setting, we're saying, okay, we have a targeted therapy, osimertinib, we're going to give that, and we're going to see what effect we can get out of that with, a median time of duration of treatment response averaging around 18 months, knowing that there are some that's a lot longer and some that are a lot shorter. But recently, we've seen a lot of data emerging on combination strategies. The guideline has already been updated to incorporate two of these combinations, osimertinib with chemotherapy based off of the FLAURA2 trial, then the combination of amivantamab with lazertinib based off of the MARIPOSA trial. And that was data on progression-free survival that was published and led to those particular recommendations. Now, more recently, we've seen data come out in smaller randomized studies for other combinations. And more recently, we reviewed the RAMOS study. So this was a phase 2 open label randomized trial for patients with tyrosine kinase inhibitor naive and really treatment naive advanced EGFR mutated non-small cell lung cancer harboring one of these two classical EGFR alterations, randomized to either osimertinib alone or osimertinib with the combination of ramucirumab, which is an anti-VEGF agent. There's been a lot of data, preclinical and clinical, for the role of VEGF blockade, particularly in EGFR mutated non-small cell lung cancer. So exploring the combination of this for synergy in the frontline setting really made a lot of sense. So again, this was a phase 2 trial that randomized patients prospectively to one of these two regimens. The population here is really what we typically see with EGFR mutated non-small cell lung cancer, predominantly a younger population. Median age on this study was 65, predominantly female, 71% female, and predominantly non-smokers. Now, what this study showed was that a median follow-up of 16.6 months, the progression-free survival favored the combination arm with a median progression-free survival of 24.8 months with the combination of osimertinib plus ramucirumab versus 15.6 months for osimertinib alone for a hazard ratio of benefit of 0.55. The landmark 1 and 2 year endpoints for progression-free survival also favor the combination arm, and response rates were relatively comparable between groups, with overall adverse events being more frequent in the combination group, specifically high blood pressure, proteinuria, and epistaxis, which are common adverse events related to VEGF blocking agents. So it's good to see data in this space. Now, of note, though, this was a phase 2 study, so not a phase 3 level of evidence. In addition, when looking at the population, this was a randomized multi-center study, but it was a US-only population. There was also some imbalance in the number of visits between arms. So the combination arm was seen more frequently than the arm that got osimertinib alone. Now, the imaging assessments were no different, but obviously this could lead to potential confounding, at least in timing of awareness of potential side effects and things being brought to the attention of investigators. So very promising data here, but because, of this being a phase 2 study, this actually led to no changes in the guideline at this time.
Understood. Yes, as you mentioned prior, it's important to understand the full body of evidence and to review the trials even when it doesn't impact the recommendations.
And I will say that, there is an ongoing phase 3 study looking at a very similar combination. It's the phase 3 ECOG-ACRIN trial of the combination of osimertinib plus bevacizumab versus osimertinib alone in this specific population. So, I think we will see phase 3 level data for a combination of VEGF with osimertinib. But again, promising phase 2 data that did not lead to a change in the recommendation at this time.
Absolutely. We'll look forward to that ongoing trial to learn more about combination in this patient population. So then moving to that second patient population that you mentioned earlier where the panel reviewed evidence, what is the updated evidence and recommendation for patients with NRG1 fusions?
Yeah, so this was an exciting update that we made more recently with this unique iteration of the Living Guideline. So NRG1 fusions, this is perhaps a newer kid on the block in terms of driver alterations that has known to be identified in non-small cell lung cancer among other solid tumors. It is very rare, occurring in less than 1% of solid tumors, but something that we know is a unique oncogenic pathway that can lead to oncogenesis and cancer development, including in non-small cell lung cancer. So up until now, unfortunately, there have not been targeted therapies that target this unique alteration. It's somewhat different than other driver alterations where there's a top-level signaling change in a protein. This is more of a ligand alteration that then alters, that then enables activation of more classical pathways, but again, through upregulation of a unique ligand. So a slightly different pathway, but something that we know should be able to be targeted to promote patient survival for those with NRG1 fusions. So the therapy here is a therapy called zenocotuzumab. It's an IgG1 bispecific antibody against HER2 and HER3. So it prevents the downstream dimerization and signaling that occurs as a result of this NRG1 fusions and upregulation of the NRG1 signal. This was, as you can imagine, with a rare alteration, a large phase 2 registrational study that examined this in advanced solid tumors containing the NRG1 fusion. This is the NRG1 registrational trial. And this study enrolled patients with advanced solid tumors who had progressed on prior therapy. Patients were treated with zenocotuzumab 750 milligrams IV every 2 weeks. Among 158 response-evaluable solid tumor patients, the response rate was 30%, median duration of response of 11.1 months, and a median progression-free survival of 6.8 months. Now, in those with non-small cell lung cancer, that made up 93 response-evaluable patients. Very similar outcomes there. Response rate of 29%, median duration of response of 12.7 months, and a median progression-free survival of 6.8 months. This therapy did appear to be well tolerated. The most common higher grade emergent side effects, grade 3 or higher, were anemia occurring in 5% and elevated liver numbers occurring in 3%. So this is a subsequent line study. So this led to the updated recommendation that clinicians may offer zenocotuzumab in the subsequent line setting for patients with advanced non-small cell lung cancer who harbor NRG1 fusion. So I think this does speak toward the incredible importance of next generation sequencing and molecular testing for patients, particularly to include testing that looks at the RNA. These large fusions can sometimes be very challenging to detect on DNA sequencing platforms alone. So it's important to, if you have a high level of suspicion for an alteration like this, perhaps some of the mucinous adenocarcinoma, where it's been challenging to find a driver alteration, and it's someone who is a never smoker, really would want to include molecular testing that assesses the RNA level and not just the DNA.
Absolutely. It's important to have all the biomarkers available so that clinicians are able to use that to inform their decision making. So then, given these changes in the guideline, what should clinicians know as they implement this latest living guideline update, and how do these changes impact patients?
Yeah, I think talking in reverse order of what we just discussed here, there is a new guideline update for NRG1 fusions. So I think making sure that that's being evaluated, that clinicians are testing for that and really looking for that result, that should be incorporated in most next generation large sequencing assays to get that result. But it's very important that that is not overlooked now that we do have a therapy that's available in the subsequent line setting. Though it is important to note that patients with NRG1 fusions, at least the limited data that there is, suggests that the efficacy to standard chemoimmunotherapy regimens is overall poor. So physicians, unfortunately, might be facing this question for second-line therapy in patients with NRG1 fusions sooner rather than later. For the former, for EGFR altered non-small cell lung cancer and how to incorporate VEGF-containing regimens into these patients, our guideline top-level update did not change based off of review of this new study, but it's important for clinicians to know what other combinations may exist. There are phase 3 studies looking at this combinations in the frontline setting. And of course, there is data on other bispecific molecules that incorporate VEGF in the subsequent line setting, particularly a combination that includes the VEGF PD-1 bispecific antibody ivonescimab that's being studied in the Harmony A trial for patients with EGFR mutated advanced non-small cell lung cancer, for which we hope to get some more definitive data in the coming months.
Definitely. And then you've just mentioned a few ongoing trials where we're looking for evidence to inform future updates. But thinking beyond that into the future, what is the panel examining for future updates to this living guideline?
It's a very exciting time to be in the world of treating advanced non-small cell lung cancer, particularly patients with driver alterations, because there is so much evolving data that's changing our practice in real time, again, highlighting the importance of these living guideline updates. I'd say there's many things that we're excited to see. A lot of the combination regimens in EGFR mutated non-small cell lung cancer for which there are approvals and current recommendations in our guideline, particularly osimertinib plus chemotherapy and amivantamab plus lazertinib. Those are the two approved combination strategies in the front line. We are now seeing the emergence of overall survival data for those combinations. So obviously that is something that's going to be very important for the committee to review and incorporate into guideline updates. There are several new therapies coming down the road for other driver populations. We recently saw an approval for taletrectinib for ROS1 fusion positive non-small cell lung cancer. So it's going to be important that the committee reviews the data and the publications regarding that therapy. And then there are other novel therapies that we're looking to see updated data on. There are multiple antibody drug conjugates, which take the potent power of a chemotherapy molecule and attempt to make that targeted with antibody targeting to a unique feature on the cancer cell. And there are several antibody drug conjugates that are in development at various levels of promise in this space, particularly in EGFR mutated non-small cell lung cancer. And I anticipate seeing some emerging data for that coming up in the near future as well. So really lots to be excited in the space and lots for our committee to review, to give guidance on so that these patients can really receive the top level care wherever they are being treated in the country and throughout the world.
Yes, we'll await this new data to continue to provide optimal options for patients with stage 4 non-small cell lung cancer with driver alterations. So, Dr. Royce, I want to thank you so much for your work to rapidly and continuously update and review the evidence for this guideline. And thank you for your time today.
Thank you so much.
And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/thoracic-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.